share it in just 1 minute. And we can also take a variety of inputs. So I'll keep monitoring and others will be monitoring the Zoom session to see if there are any questions along the way. Feel free to interrupt. I see a lot of common faces from before, but I believe also we have some new people who've joined us. So
yeah,
that's
I want to welcome everybody who's new to this group. We've got a number of new stakeholder partners. We've got a number of relatively new patient engagement officers and others who haven't heard any of this. And so this is going to feel a bit like a fire hose drill of lots of information. But I wanted you to know that we've got a number of folks that we've onboarded recently who are joining us this morning.
great. And thank you so much. So for people who are new as a stakeholder, this is a little bit of a newer thing for this network. Though it's been there as a theme over the years, since PCORNet's inception, being funded and created by the Patient-Centered Clinical Research Network, the predominant stakeholder has been patients. But as we move into our third phase with PCORI, they've charged us with increasing engagement with a variety of different stakeholders who would have interest in supporting research and especially comparative effectiveness research. So I've got a slide deck that kind of describes a little more of the building of the, not as much the building initially of the network, but kind of an introduction to PCORNet, and then has a little more on observations just on how it's been created over the years and what's happening in the general field. And then we also have hopefully time for questions towards the end. Some of these slides may look daunting, but I'm hopeful that will minimally hopefully confuse people. Okay, so I'll give an introduction on PCORNet. I'll talk a little bit about how health data has evolved, and then I'll touch briefly on, as our sub-network of PCORNet called the Greater Plains Collaborative, how we've done projects kind of to take advantage of health system data in different ways. And then probably I may skip the emerging topic area because it'll be covered in the next session as well. Okay, so if you go back to 2010, there was the Accountable Care Act known as Obamacare, and in it, probably a less controversial component was it created a new funding entity called the Patient-Centered Outcomes Research Institute. And shortly after that was created in 2010, and Joe Selby was the founding executive director, they really saw to advance comparative effectiveness research for more patient-centered trials. So if you're familiar with research in general, I would say there's a concept of basic research where you may study the basic biological mechanisms of disease or health in general, and that may often take place in mice and animals. And then those trials move into humans for the first time, which is called translational phase, T1 phase trials. And then it will move to, if let's say we were discovering a drug, to a drug being approved for human use. But as more and more therapies accumulate, what may matter most to patients is not that this drug is approved by the FDA, but what drugs do I choose, or what drugs versus other therapies do I choose? While the Food and Drug Administration does a very good job of approving medications that are safe and effective to a certain degree, a lot of times the trials that allowed their passage may have been done in a very narrow population of people that may not represent the breadth of patients with the condition or potentially that would benefit from its treatment. So that's kind of the grounds of what PCORI is interested in helping the nation study, that traditionally has been overlooked by industry studies and by studies with the National Institute of Health historically. So as they thought about how they would support research for more patient-centered research, they said the challenge is often that once the study is defined, it's narrow, so it may not answer the questions that matter to most people. And the process of building up large study teams, building new data infrastructure for each trial is very expensive and slow. So it was hoped that if we could create a network called PCORNet that was a network of networks that took advantage of the fact that kind of just a little bit before PCORI was created, the HITECH Act encouraged physicians and hospitals to acquire electronic healthcare records. So the thought was, if we could take advantage of the fact that now, instead of having all our health records on paper, they're increasingly becoming electronic, that may allow us to both support large observational studies, so we can look at just the accumulated data, as well as still doing traditional trials that are prospective with patients. So the goal of PCORnet was to try to think about, can we make research better as a network combined of networks with research teams that think about research, but also patient care, streamline processes, and have a patient voice throughout the course of creating the network. Any questions at that or observations? Okay, so PCORnet, being a network of networks, it's composed of what are called clinical research networks, and we, the Greater Plains Collaborative, are one of them. Patient partners are involved, and then there is a coordinating center that has several components you'll learn about today, and that together is the network. And in addition to networks of these things called clinical research networks, you can also think about the fact that the clinical research networks in many ways are based at places that deliver healthcare or health systems. And that often employs or has affiliations with many clinicians, and the patients come to the health system. But as a network, we're also motivated to think about, there may be other data that isn't accumulated by the health systems that we want to integrate and link to. So throughout the course of the day, and also in follow-up, if you'd like to learn more, there are places where we may link to things like insurance claims, traditionally, that augment the data that's held by health systems. So let me think if I can see someone here. So if we were to talk about, I see Cass is on the line from Alina, and Alina has a variety of primary care clinics. It has specialty hospitals. And in contrast, we may have another campus that is more specialty care. So perhaps the University of Utah, where it looks like Megan Doros is from, is more of a specialty referral place than Intermountain Healthcare in the state of Utah or that region. That just play with that premise for a little bit. And so if you mainly see people for specialty services like cancer treatment, certain orthopedic procedures, you may not know as much about the health of the patient before they come to see you, or how ultimately they recover and how they progress after they come for your specialty procedure. So that's an example of, if you had insurance information or information before they came to see you and after, those are external data that can help you get a better picture of health. Okay, this is a map of the national network so far. And so we are the orange network, the GPC, and you'll see that we have colleague networks that are covering a large part of the United States. So I will go in no particular order, but Advance is shown in Oregon, but it also has partners in Florida and partners in the Northeast. And it's composed of safety net clinics, and I think they're adding more safety net hospitals, so that they provide a perspective on underinsured or uninsured individuals in many locations. We GPC are in orange, and so we have partner organizations throughout the central United States. And then the next one geographically, I would say, would be ReachNet, which is based headquartered in Louisiana, but also has Baylor Scott and White in Texas. And then there's a network called STAR, and STAR is composed of, it's headquartered at Vanderbilt and originally had the Mid-South, but then it added the Mayo Clinic, which also has campuses in Arizona and in Jacksonville, Florida. The next network would be PATH, which is based out of Pittsburgh and has partners in Michigan, Ohio State, and then in the mid-Atlantic region, Johns Hopkins, Temple, Penn State, et cetera, here in this area here. The next network, I would say, would be One Florida, which originally started out as just institutions within the state of Florida, headquartered at the University of Florida, but has now grown to add University of Alabama, Birmingham, and Emory University in Atlanta. The next network would be PedsNet by geography here. It's based at the Children's Hospital of Philadelphia. And in blue, it also has partner institutions at children's hospitals stretching across the country. So going, from places like Lurie Children's in Chicago, and then moving to Colorado and over to, I believe that's UC, I can't recall if that's I think it's Stanford's Children's Hospital. And then finally, we have Insight, which is based in New York City and does interesting work to link data across the variety of hospitals in the New York City area. And their network is based at Cornell University School of Medicine. Any comments or questions? Okay. So underlying, I'm sorry, was there a question?
That's Kim. Yeah. So thanks for going through all the networks. I always learn something when I look at all the dots. Can you speak a bit to whether this distribution of all these players was purposeful? Was it accidental? It looks like the northwestern portion of the US is kind of left out of the story. Tell us a little bit more about how these networks kind of organized, I think, to better describe why the distribution is the way it is.
That's a great question. And thanks, Kim, for reacting that way. If we were to go very back in time, PecorNet was created, essentially there was a funding announcement in 2013 and it started funding in January of 2014. And in that initial wave, there were other networks that were funded. Both our networks like us, what are called clinical research networks, they were called clinical research data networks originally. And it also funded what were called patient-powered networks, which would be great to go back to, but they were actually activated groups of patients. And they were scattered across the country, but predominantly rare disease and common disease focused. But to your point, there were other networks funded that over the years, through the changes in the nature of how the network was funded, we'll talk about that transition later, certain networks decided not to compete for additional funding, and other networks did compete but were not selected. So notably, to Kim's point, there was a network that I believe still exists and is used as a different data model called PScanner, based at the University of California, San Diego. And PScanner originally encompassed much of the schools in California and also had partnerships in Colorado. Equivalently, to your point, in the Northeast, there was originally a network called Skills, and I believe its first name was Arch, and it was based at Harvard University. And it originally encompassed many of the health systems in the Boston area, but then also had partnerships with other institutions, such as, I think Emory or Grady Hospital used to be part of their network, along with Houston, who's now part of our network. And then there was also a network called Capricorn that was with us up until this funding period that was based in Chicago. Capricorn is still there. They're still maintaining their common data model, but they're not officially funded by PCORI right now. Is that helpful, Kim?
Yeah, that's helpful. It's just when you look at the map, there's a story to be told. That's all. And I love the map, but you left out a little bit of the story. So thank you for filling it in.
Oh, and I'll tell you, everybody chime in, because I'm telling you a talk right now from kind of how things are positioned right now. But you're right. For people just joining us, we've been on this voyage now for 8 years, a little over 8 years. So there has been a lot of history. And so if you thought about the original design with PScanner, you would say geographically, we used to have a higher concentration in California, and that we don't have, as well as the Boston market area. Thank you. Okay. Well, underlying this network is data, and you'll hear a lot of the conversation today and in extra meetings happening over time about the common data model. And the idea of a common data model is different hospitals use different electronic healthcare systems or have different feeds of data that may be things like insurance data that has information about healthcare, but it's not coming from an electronic healthcare record system that's used by clinicians. And so what has happened at PCORNet, and it builds upon prior work for the Food and Drug Administration for a project called Sentinel, And it also builds upon other efforts to standardize data for research, such as the Odyssey effort based out of the Northeast, Columbia University and Janssen Pharmaceutical, as well as I2B2 efforts based out of Harvard and Pittsburgh, is you can take data from different database systems used by places and then standardize them into tables and columns and fields where they're harmonized and their data quality is checked. So for example, you could have a table for all the patients and have a data about them of are they alive or dead? What diagnoses were assigned to them? Yes, they had heart failure, or they currently have heart failure. Yes, they broke their arm. Their arm is now repaired. Yes, they're taking a drug called metformin that may be associated with their diagnosis for diabetes. So those are examples of places where we have defined a common data model that evolves every year or so to add additional columns and tables as we standardize data across the network. There's also other tables or other data that may be integrated that isn't yet fully standardized across the entire network, but is evolving to be either linkable, where people link it to their common data model, or actually starting to bring those in. So some examples of that shown here are things like when you have an address on an individual, you can do what's called geocoding. Kind of if you were to look at Google Maps, you can precisely put a dot on the map for where they are. And then you can take advantage of that to understand what are other attributes of where they live. Are they in a rural area? Are they in an urban area? What's the typical income in that area? Is it a food desert, et cetera? So that's geocoding, which is not specifically in the common data model, but a lot of the basic data for how one could do it is in the data model. So networks take advantage of geocoding. There's increasing interest, and it's not yet fully standardized, but over the next 3 years, we will probably make strong inroads to link to or integrate social determinants of health. Some of that information could be things like, are they bilingual? Are they, what type of house does someone live in? And that information, we may either evolve the data model to explicitly have a place to put it or link to it. If you were to look at healthcare right now, sometimes that data is actually asked of you when you come to visit the hospital or clinic, but in other cases, the data may be available via other means. For people who have cancer or are treated for cancer, hospitals will collect what's called a tumor registry file that tracks in greater detail the information about the diagnosis and treatment of the cancer, of the tumor. And that's a table that we in the Greater Plains Collaborative started prototyping and using from the beginning of our network. And we've kept that alive, but we want to standardize it into a more consistent table design for use for supporting cancer research. Sites may maintain biospecimens and biosamples that's highly related to cancer research, but that's an area where different organizations maintain that data that may be linked to their common data model, genomic results, patient-reported outcome measures, where the patient's actually recording, how their recovery or how they deal with their heart failure in terms of mobility or exercise is denoted. And then there's a field of what is called natural language processing, where if you look at the healthcare record, while some data is very structured, it's kind of like a 1 or 0, yes, you have the diagnosis, or no, you don't. A lot of the intake and physician assessment of patients and then developing plans is recorded in text notes. So kind of like just a narrative note, they either dictated it or they typed it in. And so there's a approach to technology called natural language processing, where you read that language of the note and then you extract information from the note in a structured way. And we as a network aspire to get better at our ability to manage that data, with the trickiness that because it's free text, it's often loaded with protected health information. And then finally, there's interest and different efforts across the network to link to patient-generated data. A classic example might be if you wear a smartwatch that has fitness information about you and tracks your activity. That could be very interesting data for certain questions. Any questions on the common data model? Okay, so let's give some examples of how this thing gets used. I've chosen a couple things we've done and are currently doing just to give you a flavor more on the trial side of how the network gets used. So the main trial we're working on right now, that's probably the largest trial we're working on right now, in terms of activating sites and actually having to contact people, is called Preventable. And it, based upon looking at a lot of prior data, it is suggested that drugs that lower your lipids in your blood, there's a drug called atorvastatin or Lipitor, it may actually be good for your health and may prevent you from suffering dementia. And so what we're doing, and this is a study funded by the National Institutes of Health, it's called the National Institute on Aging, and we're recruiting 20,000 people who are much older than just on Medicare. They're over 75 and they're largely healthy. And then we want to see if they're interested in being randomized to either take a placebo, a sugar pill, or take Lipitor. And then we're going to look at their existing healthcare record data. We're going to look at their Medicare claims data and then do phone surveys to see how the study turns out. And they'll receive medications directly to their home from the study. And so while the study is currently underway, we've had over 4,000 people enrolled in the study. It's notable that because much of this study is contacting people on the phone, looking at their existing data, we were able to keep the study going during COVID with only one small change to the research protocol and the institutional research board review. So that's an example of a large pragmatic study. Pragmatic means kind of like, it's pragmatic, it's real world, you know, not as controlled of an environment where the people are being studied. The one we completed previously that was kind of our first demonstration project for doing a large study of individuals and contacting them was called Adaptable. And it was asking the question, if you have had a heart attack or you've had a catheterization procedure to roto-rooter out your heart, it's thought that you should take aspirin to prevent subsequent disease. But there's a risk that aspirin thins out your blood and may cause bleeding. So people don't know, should you take a big pill of aspirin a day or a little pill? And so we were able to, while we were building the network, deploy this study and recruit over 15,000 people to swap, to be randomized to one dose of aspirin or another. And that was completed, although at the time initially we were worried about recruitment getting it going, but we were actually able to recruit in 38 months, which was pretty good by standards of doing a trial this big across only 40 sites. We had a fairly strong patient engagement throughout the effort, although there were components where, you know, when you're doing something this large and national, getting input from all voices is quite a challenge. But we had involvement from patients and clinicians called adapters. Well, actually, the patients were adapters who then also further engaged clinicians on the trial. Any questions on those trials? These are not observational studies, so these are not data-only studies, but I wanted to highlight some trials where we're actually, especially for stakeholders, know that this network can go out and contact patients to enroll them in randomized trials. Any questions? Okay. The next one I just wanted to share is if you look at other networks of data, of places that combine and aggregate data, I would just say PCORnet, and this is probably a little biased by us, but it tries to say we cover all the bases. We can do feasibility queries so people can get an idea of how many patients are out there for the question. Then you can find patients for a trial. And then you have a process we go through every quarter to check the data quality from sites, because you'd be surprised, even though a hospital is around for a long time, the number of computer systems it uses can change over the years. They may change their billing system. They may change components of their electronic healthcare record system. They may buy another hospital, which uses a completely different healthcare record system. So knowing that you don't have gaps in your data takes attention. And so PCORnet, I would say other efforts do data curation and quality checking, but there may be a greater degree in PCORnet because we actually track it, give feedback, and seek people improving their data. And then, of course, PCORnet is, there are some also very large, good data networks, but they may have less of a connection to patients and providers. So this picture, we'll post these slides afterwards, but basically this report that you'll hear people at all the campuses and sites and health systems talking about is called the Empirical Data Characterization Report. And it isn't meant to be exhaustive, like once you pass it, everything is perfect, but it gives you some high-level checks to say, if someone had an encounter at the health system, they should have a diagnosis and procedure most of the time. So you'd be surprised, over the years, there have been some health systems where they forgot to integrate their billing data, and you wouldn't know who had certain types of procedures, which is very important if you're trying to know if someone had a heart procedure or a knee surgery. So those are examples of these investigative checks and required checks that happen in the common data model. And over the years, the sites have gotten much, much better at data quality, but we'll continue to do that. So it has a cycle where the queries are distributed, reviewed, and approved. And the network sites also comment upon what discrepancies can they think they can fix versus which ones are really going to be hard to fix because of perhaps lack of data from the health system partner. And then it also has really nice visual trends. So if you get a chance looking at this slide, you'll see that this trend is showing you ambulatory visits. So kind of your typical doctor's office visit plotted against telehealth visits. And it's really interesting at Missouri, you'll see that we were going along and then something happened in April 2020. And this uses a Z-score, which kind of shows the amount of deviation from the prior month. And you'll see, whammo, huge reduction in ambulatory visits in April, huge rise in telehealth visits. Now, this is not a data error. This reflects COVID. So you can really see visually the impact of COVID on reducing visits to the clinics and then its subsequent rise. But then also we kept doing more telehealth, although it's kind of drifted down lately back to where it may have been before or a certain percentage. So that's an example too, where you can visually see how data looks. It may not be a quality issue. It may help you understand what's happening with your data and your organization. Any questions on the data quality topic?
Hey, Russ, this is Kim again. Can we pause? Because I think that graphic, again, nobody knows how to calculate a Z-score. We all get it, but we get that these are noisy bumps, right? Like, whoa, something happened. So this tells a story for our site, certainly, about the way we were taking care of people. I also think this provokes a couple of questions we might have, which is, why did we stop doing telehealth? What is driving the decrease and lowering of that green line and the kind of bumpy rise of the, is it red? I don't know. Maybe I'm red-green colorblind here, but the other line is increasing, right? So the point I want to make is that the data are dynamic. They let us ask questions, right? Like, what's going on? There's this crossover point that looks like it's around April of 2021, right? Where it looks like it's kind of the two lines cross one another. Maybe you could point to that with your pointer. I'm pointing with mine. That doesn't do me any good. Right
Yep,
there.
right in there. Yep.
Right. So what I'm trying to highlight here for our team is that the data let us ask additional questions. It's not just tracking, but now we can ask questions about what were in policies, in payment models, in changes in guidance from the CDC about COVID, like what caused this change. So we can ask researchable questions when we can see the data displayed like this.
Yes, thank you, Kim. Great example. And, there are some things that just you can speculate on, but at times what's also key in PCORnet is we can go back and talk to leaders and team members at the health systems, because it could be some of these blips in the past could have been maybe they acquired a new clinic practice group. So they saw more visits because their health system grew. The Z-score dropping down here, it may be actually at a higher level now, but it hasn't been changing in a high way for a while. So that's a very good question, but you could think it's, well, kind of thawing out from COVID. People kind of went back to business as usual. We shall see, but that's exactly right. Okay, so some summary items here just to remind people is that PCORNet can be used for real world evidence studies. To Kim's point, it could be used for health system research of kind of understanding how is the health system working. It can be used for studying the health of populations, though we always have to keep in mind it's not exactly the whole population in our region. It's people who come and seek healthcare services, which are often not as healthy as the general population. It can do these large pragmatic studies and trials. And then it can also be used with the expertise of the patients in the network and the network itself on how to engage patients in research. So I'm going back to the picture. This is just to give people a visual breakdown of our network, the Greater Plains Collaborative. We estimate we have about 30 million people in our network, with some with fairly light touches with us. But this is an updated map of where our patients from our 13 health systems come from. So as we integrate Medicare and Medicaid claims data, we're actually going to be purchasing more claims data from 2018 to 20. And Dr. Song will talk about that, but you'll see that we've decided we'll probably pick up Idaho, since we have a lot of penetration there, and Nevada, and we already have some data from Wyoming. But this kind of gives you a picture of where we come from. And we're also going to probably pick up downstate Illinois because of the patients seen by University of Iowa, which is more on the east edge of Iowa, as well as Washington University BJC Health System has facilities in southern Illinois.
Hey, Russ, this is Kim again. Sorry, I keep bumping in here. What's the difference between the light blue and the dark blue shading, did you say?
It's the number of patients in that county who have received, had a healthcare encounter with the facility. So it's kind of showing you that it's best seen in Nevada because it's such a big state. So, down where Las Vegas is in the lower corner there, it's very dark. Okay. As you go up, there's some other dark spots up higher because there are a lot of patients who come to an Intermountain healthcare facility, but the lighter colors are places where, proportional to the number of people in the county, they may not be receiving as much healthcare services as others. Is that helpful?
Yeah, so the darker the blue in this case, the more patients are represented from those areas. Is that correct?
That's correct.
Okay.
So if you look at it,
North Dakota is left alone, right? Like we have very little activity and very few patients seen in our network. Their data aren't in our database because you can tell that state is pretty much not, their healthcare needs are not met by our partners.
That's right. Yep. Okay, and then Kim, we wanted to talk about patient engagement layers in our network. And Kim, would you like to cover the engagement circles?
Sure. Thanks, Russ. What I thought would be a good idea is kind of to back up to where we started 8 years ago with our model for nested circles of engagement across all of the Greater Plains Collaborative. So here's the basic idea. At the local level, for each of you at each of your sites, you have a patient engagement officer, someone named to help be a bridge between our informatics research teams and our local patient partner work. And you have a patient advisory council member, an individual who brings a patient and community experience voice to the table. And that pair works at the local level to collaborate with local investigators who seek to use the Greater Plains Collaborative data. So they can bring in ideas about particular community partners, for example, who might be a great match for a study. They can recommend that the group of researchers access the overall Greater Plains Collaborative engagement team for some help. So they are your local connection to engagement. Those folks help us build out our research studies and help us coordinate across this entire huge enterprise that Russ has been describing. And they also play roles in our governance and provide overall overarching input into how we're doing the work of the Greater Plains Collaborative. And that feeds into Precori's PCORNet model, which is that we have authentic and sustained engagement from folks who are not in the middle of research, but who are strongly influenced and want to have a voice in the kinds of research questions we ask and answer. So we have these nested circles that are part of our model. It's changed a bit over time, but fundamentally it remains a patient engagement officer plus a patient advisory council member together working with the local informatics, the biomedical informatics team, and the local investigators to help access the rich resources of the Greater Plains Collaborative. So I wanted to share this model. It's one that has served us well. And as I said, it's modified a little bit, but this is what Cheryl Jernigan, who's on, good morning, Cheryl, and I helped build in our first model, and we've maintained it. So I just wanted to share that.
Thanks, Kim. And as well, you kind of go local to regional to national. So they can also provide a voice to help bring studies to the broader network. And there are opportunities for our patient leaders and now with new stakeholders to play a role in the national network and national activity.
The other thing that we've done is establish some shared values and some ground rules. And so one thing that Russ didn't tell you, but I'm going to tell you now, is that throughout the day today and Thursday as we meet together, we invite you to use your reaction button in Zoom. Pick any bird of your choice. We were trying to find a Greater Plains prairie chicken, which is our logo. We love the prairie chicken, but there isn't one. But you can pick a duck, an eagle, pick whatever you want. And if you throw out that reaction icon, we'll stop and always interrupt the conversation and make sure everybody is participating. So when we all meet together, Russ, I don't know if you've got a prairie chicken with you that you can show folks when at some point. But we have these little prairie chickens. They're little stuffed animals. And from the very first time we met as a group, we used those as a way to sort of flag jargon patrol. We could identify that we were getting lost because there was an alphabet soup of acronyms, or things were moving along too fast and we didn't understand what was going on. So anyone can interrupt and slow the pace of our work. And the way we do that when we meet together is to use these little stuffed prairie chickens. But in the absence of having a prairie chicken to throw, please use your reaction button anytime you need something defined, or if we slip into some jargon that is difficult to follow, we invite everyone to stop. Usually I'm the one who's throwing the bird, but all of you can identify a way to slow things down so that we can all understand together. And that's part of a ground rule of how we work, to be transparent, make sure that everyone is able to join in the conversation and that everyone is respected for what they bring to the table. We also have, throughout what we've built for the Greater Plains Collaborative, a real commitment to recognizing the value of each person's contribution. Everyone's lived experience, everyone's professional experience brings to bear great richness on the work that we do, and we honor that. And so we always make sure that we keep the focus on our participants and leverage all of that enthusiasm and everything that you all bring to the table, so we're listening clearly for those insights. These are the shared values we have. We usually throw these ground rules up every time we meet, so I thought it was a good idea to include them in the slide deck. I think that's it, Russ. Back to you.
Great. Any questions or comments?
Anybody find a bird to throw up? Because it'll pop you to the top of the list, and we can there, Russ is showing, if you guys can see him in the video, he's holding up one of our stuff.
This is our original series, but they don't make them anymore. So
does it still squeak, Russ, the original one?
Very quietly, he's very faint, but he's still squeaking. And then this is our crocheted chicken that we found a lady on Etsy who makes them. So yeah.
It sounds sort of silly and it's a little whimsical, but the purpose is really an important one. And that is that we have to flatten and identify common language we can all use to understand what we're trying to do. So please feel free. Russ sometimes will spin off into a bubble. So will Jim or anybody else And so just call it. Just call it out so we can go back and make sure that we're all communicating as clearly as we can. Thanks.
Great. Well, I wanted to give a slide just to give a little historical context, but also tell people a little bit more about how we got to where they are. It's probably personal to me, but if I go back and look at my career in kind of biomedical informatics, when I was at Vanderbilt for a long time as a student and faculty, we were building electronic healthcare records that weren't fully baked kind of for all the clinical needs. We are also doing artificial intelligence and doing works in commercialization. And a lot of that work was very good. We could deliver great decision support to clinicians, but data were not very standardized. So what was learned at one institution was very hard to translate to another institution. They may not have the healthcare record. They may not have their data organized the same. And so what we saw from the next phase, was that in the 2010 time period, that was a couple of years after the federal government, incentivized with billions of dollars to have health systems buy electronic health records. And in parallel, the Institute of Medicine, kind of promoted the idea that health systems should be learning. They should be continuously learning health systems. There is an acronym here called the Clinical Translational Science Award, which were kind of the larger research organizations supporting all kinds of research in the country. And they were trying to figure out how they take advantage of these new electronic healthcare records to support research and let people start to discover new knowledge and relationships. And then, as we said, PCORI, after creation, took a couple of years to put out the funding announcement to create PCORnet. And you saw a large focus on how do we get the data standardized, and then how do we govern sharing of data? How do we govern a network trying to operate? And PCORnet was not the only network. There was another network based out of the NIH called ACT, and another network called All of Us that you may still hear about that's very active for cancer research, trying to consent patients to share their DNA and their healthcare records. So this PCORnet is a very strong network in the country, but we want to acknowledge other networks, and we all learn from each other in terms of how we operate networks. So it's also worth pointing out, when you look at our history, we had an event happen where Donald Trump was elected, and I don't think he had it out necessarily for PCORnet, but if the election had been successful in repealing Obamacare, that would have deauthorized the existence of PCORI. So there was concern in that election of how do we keep the network going when we were uncertain about its funder still existing. So not unlike the escape pod in Star Wars, we had a entity called the People-Centered Research Foundation was created to hold PCORI funds to keep the network operating at what was called a keep the lights on mode until the network was reauthorized, or PCORI was reauthorized at the very, very, very end of 2019. So that's kind of a transition period that actually started earlier in planning mode in 2017, 18, but then we maintained the network. And we actually didn't just maintain it, but we continued to do a lot of studies, and notably the preventable study was initiated during that transition period. Then with PCORI's reauthorization, PCORI sustained the network and basically resumed funding the network directly in 2020, 2021. And in 2021, they put out a funding announcement to renew the network infrastructure for an additional 3 years, which just started this January. Along this voyage, there are several new priorities that are highlighted by Congress to PCORI, as also are articulated by PCORI. So that first acronym, social determinants of health, will have increased importance. Maternal morbidity and mortality, and help also understanding and improving health of people with intellectual and developmental disabilities will be areas where we'll see more focus for the network and for PCORI as a whole. Specific to our network, some of the things we want to tackle in phase 3 are taking advantage of cloud infrastructure to have more common computing capability and streamline data infrastructure. We want to make sure we solidify our tumor registries for cancer, scale that ability to do parsing of notes and extracting information consistently. We have a later goal of almost all campuses use a system called REDCap, which is a free system for managing data for trials. And they have new capability to talk directly to EHRs. So we think having that capability will be important for certain trials. We want to support that. And then we have goals as well on resharing with sites death status from the federal government so people can know who's died, as well as linking to the Veterans Administration. So those are kind of goals for the network going forward. I'm gonna just don't go into these pictures in too much detail, but I just wanted to highlight from our network's perspective some studies in different data infrastructure. So another large study done initially in PCORNet was looking at what's called bariatric stomach surgeries, and there are 3 common procedures. And we were able to support this study, joining with the rest of the network to look over 100 million patient records to find 65,000 people with these different procedures and understand which one has the greatest weight loss relative to the risks. And this study was done with what I would call PCORNet classic data infrastructure, where the investigative team wrote code in a statistical package called SAS. That code was deployed to the sites, and all the data infrastructure stayed at the site level. We've also done work for GPC investigators and for other requests where the complex analysis made it difficult to do the analysis in a fully decentralized way. And so in these scenarios, what would happen would be the sites would take a cut of their common data model, give it to the investigator, and then she could run, in addition to SAS, she could use other statistical and programming languages like Python and R. So that was an example of another type of study in PCORNet that you may hear people, if you get on the data side, involved with. The other scenario is PCORNet was also charged us with linking to claims data. So at the GPC level, we created a centralized warehouse where we could store the Medicare claims data and then link it with de-identified copies of the tumor registries and the data warehouses. And that allowed us to have richer characterization of people with breast cancer in a project funded by PCORI. And we've now moved that onto a consistent cloud platform hosted by Amazon Web Services, where we also get a discount on movies, just kidding. But then we also have a rich database technology called Snowflake that allows us to really isolate and understand what's consumed in terms of how much computing for various projects. And that's currently working pretty well for the network. As mentioned, I would say in closing, we have that centralized claims environment, which is governed by an IRB protocol, and it also allows us to go purchase more Medicare claims data. We'll continue to use it for the 3 cohorts that were created when we started GPC for just our network. And that is the whole PCORNet focused on understanding the consequences of healthy and unhealthy weight. So if there are projects specifically related to that want to look at very big data and the insurance information's ability to fill in the picture of health, you can always let me know. We have a working group on that. We're also interested in, and we currently want to move forward some activities looking at intellectual and developmental disabilities that we published on in the past, cystic fibrosis, sleep, and heart failure. ALS, or Lou Gehrig's disease, has been our rare disease of interest. We've had a number of proposals go in for prospective trials, and Dr. Sing Song was just awarded a grant from the Centers for Disease Control to do rich analysis of that population. So that's going to be an area we'll continue to focus on. And then also our common condition is breast cancer. And again, as mentioned, we'll be working to organize our notes so we can do the natural language processing. We'll be working on the tumor registry and the real-time EHR integration. And with that, that's the end of my slides, but we'll take time for any comments or additional questions. Hopefully this was helpful overview. I know some people have seen the materials before, but welcome any comments or questions, or people who are on the patient advisory group. If you see new people, It's really a nice forum to, we talk on a monthly basis, but if there's anything that could help, just please speak up.
Hey, Russ, do you want folks to just raise their hand if they'd like to make a comment?
Sure.
We got 66 people on here. It might be hard to find them.
Okay.
Well, Russ, this is Jim McClay, and I was going to ask or comment that you had mentioned this concept of a learning health system. And I didn't know if you wanted to expound on that a little bit and the value of the learning health system to overall health improvement.
Jim, I would think you are the ideal figure to expound upon that. And so Jim McClay is our dual principal investigator.
Yes, hi, everybody. I come from a background in healthcare. I'm an emergency physician. And so my career has been on trying to do things better through systems. Partially because I have an engineering background and partially because, like all program developers, I'm essentially lazy and I don't want to do the same thing over and over again. And the work that PCORNet does, the research and the interactions with health systems around the country has a real value in feeding back to how we practice medicine and how we care for our patients and how we care for our communities. And so that concept of doing research, doing introspection on our outcomes, and then systematizing that and rolling it back into how we care for patients is the concept of a learning health system. And the underlying thought process in a lot of this work is to recognize where we have gaps in our knowledge, and that's where we apply our research efforts, but then to look at how those outcomes can be probably saw that historically over the long time frame it took to go from a research finding to actually using it in healthcare. And I will say that COVID has taught us a lot about that. With everybody paying attention, we can see, and you can see in our graphs, like the telehealth, that we made rapid changes in the way we practice medicine and the way we care for our populations by doing rapid research projects, some of it fed by the PCORNet infrastructure, looking at the outcomes, deciding we can do things differently, and rolling that right back into the way we care for patients across the country. So that's the learning health system that Russ mentioned.
Thank you, Jim. Other comments or questions that people have?
Jim, I'm sorry, can I jump in and ask Jim a follow-up question? So Jim, can you give this team an idea or give a concrete example of the kind of research that we've done through PCORNet, or whether it's adaptable or preventable? Walk through a way in which we've used this ginormous data system we've all collaboratively built in a way that has informed the learning health system goals you just laid out. Where have we gotten this right?
Well, we started, it took a long time to do, for instance, the adaptable trial. That was a study that would not have been done without the PCORNet infrastructure, because the funding for studies is generally for novel or ideas, or because it's important to the commercial funding organizations like pharma. And the dose of aspirin doesn't mean a thing to anybody who's selling aspirin. But it's important to our outcomes for our patients. So the results, by the way, of the adaptable trial showed there was really no.
It's frozen right at the punchline.
I guess everybody.
You froze on the punchline. There wasn't a major difference, I guess. Yeah.
Yeah. Sorry, was that a spoiler?
Yeah.
It was.
Sorry. Well, but taking the infrastructure we have for PCORNet, we fed it into COVID And many of us reported directly to the Center for Disease Control. And we also were involved in studies of some of the medications that were being used for COVID. Because, let's be honest, we knew nothing. We had no treatments. We, being the medical community, we had no treatments initially. And by using the infrastructure, we were able to rapidly look at the results of, say, hydroxychloroquine on the outcomes of COVID. And when those studies were published, we could look at our data and see an immediate, within a month, significant decline in the prescriptions for hydroxychloroquine because we recognized that it didn't work well. Coinciding with that, there was also studies that came out that showed that steroids did help. And so we saw a rapid rise in the prescription for steroids. And so that's where you could ask a question, get an answer, and change the way we care for patients.
Yeah, but Jim, you did hang on that punchline, which was great. I was on the edge of my seat. So our engagement team was quite frankly shocked that doctors didn't have guidelines about whether they were prescribing baby aspirin or regular dose aspirin. It seemed like a lot of us have gotten, older patients have gotten that advice, but to learn that there wasn't really an evidence base for one or the other was a bit surprising. So then we go through the whole trial and learn, kind of doesn't matter, one or the other, one doesn't outperform the other. So a baby aspirin performed equally well to an adult dose aspirin, right?
Right.
Where did we get that information back to patients? Have we closed that circle to now tell both the prescribing community, those caring for folks at risk who are prescribing aspirin, and the people who were in the trial themselves? And there were a lot of people in that trial, right? Have we gotten that word back to everybody and disseminated the results?
The results were disseminated. The typical way results are disseminated is a paper is written and it's submitted to the editors of a prestigious journal, and they read through it and they decide they're going to publish it, but then they ask for changes and it gets sent back to the authors for changes, and then it gets published in a prestigious journal. And if we're lucky, it's important enough to the lay press that they create a press release related to that gets picked up in the media. And that is, for the most part, the extent of dissemination. For adaptable, there was quite a bit of community outreach and a website for anybody who was interested that they could see the results. But the process of getting it actually at the point of care and where doctors would be advising patients is still a long series of steps and hasn't been solidified yet as to how we would do that or even who would do that. So unfortunately, we have not fully closed the circle, Kim.
All right, well, thank you, Russ, for the wonderful orientation and everybody's participation discussion.